Hello, everybody. Thanks for joining us today for the first installment of your ACR TI-RADS webinar. This one is on This is How We Do It. This session will be recorded and made available after the webinar ends. My name is Jenny Hong, and I'll be moderating and presenting today. I'm a neuroradiologist at Duke University. Now, let me introduce you to our speakers today. Hi, Bill. Hi, Franklin.
Hi, Jenny.
Hello. Dr. Franklin Tesler is a professor of radiology at University of Alabama, Birmingham. He's had more than 30 years of thyroid ultrasound experience and a deep knowledge of the literature, and he took on the role as a chair of the ACR TI-RADS committee and was a sensational leader. Through the process of working with him, I also learned that he was capable of writing very long emails. Dr. Bill Middleton is a professor of radiology at Mollenkrodt Institute of Radiology. He is a national leader in thyroid ultrasound as well. Bill was a key member of the ACR TI-RADS committee. In particular, he had available a multi-center study with the Society of Radiologists in Ultrasound, and it's through his work with that society that we got a database of more than 3,400 nodules, which allowed us to test our preliminary models and really make ACR TI-RADS evidence-based. An interesting fact about Bill, since we're in the Olympics now, is that Bill was invited to participate in the Olympics. Not as an athlete, but Bill provided ultrasound to the athletes. Now, my role on the committee is really pushing research forward. We have several publications which are now in press, and I'm a principal investigator on a multi-center registry project, which is funded by the ACR and also Akron. Three of us came together at RSNA, and we really felt strongly that we were on a mission to change the way thyroid ultrasound is performed. We wanted to change the management of thyroid nodules for patients and also add to the value of radiologists and other providers. And this is why we were motivated to do this webinar. We were not asked to do it. This is through our own initiative because we really feel strongly that the next step forward is to share what we know and what we can do with you. None of us have any disclosures of relevance. And here is the agenda. When we got together, we decided that one webinar was not enough. So we have three, and I'll tell you about the others later. But first of all, the agenda is for Franklin to take over first, and he's going to describe ACR TI-RADS. He's going to tell you about the rationale of the committee, and he will give you some tips on implementation in your practice and how you can use it. Then Bill is going to spend some time going through cases with you. He's going to go through the lexicon of ACR TI-RADS so that you can interpret your nodules with confidence. And then I'll finish off with a short presentation of the structured reporting template that you could use and also give you a website where you can get some additional resources. Then the last part of the webinar, hopefully a good 20 minutes of it, will be time for you to ask questions. And so feel free to send your questions in during the talks. I'll collect them all at the end and we'll send them off to the speakers and they can answer your questions. Now, remember I said this webinar is going to be recorded, so if you still have to step away or you think that someone else you know would be interested, you can access the recording after this webinar is finished. Another feature that we're going to add is some live blogging. This is through hashtag ACR TI-RADS, and you can mention Radiology ACR or Franklin and myself. Now that we want to learn about you. Who are you? Are you a radiologist, a radiology trainee, a physician who is not a radiologist, a sonographer, or other? Send your answers in. In this time, I also want to acknowledge Lauren Hicks, who has been organizing this webinar behind the scenes. Okay, so 3/4 of you are radiologists. Great. The next question for you is, Are you using ACR TI-RADS? Yes, no, but you will be doing it in the next 6 months, and no, no plans in the near future. Now let's take a look at your answers. Great. Okay, so I really think that this webinar is going to be of practical use to all of you, particularly the more than 80% who are actually using it or will be using it in the near future. Now I'm going to give the presentation over to Franklin, who is going to do the first part, really laying down the foundation behind the rationale, implementation, and tips to use in practice. Franklin, you should have control now.
Thank you, Jenny, for that kind introduction, and thanks everybody for attending. Thomas Wharton named the thyroid gland in the 17th century. He thought that it resembled the ancient Greek shield that's depicted on this coin. Little did he know what he was starting, because he certainly didn't know anything about thyroid nodules. And in fact, he thought that the function of the thyroid gland was to lubricate and insulate the neck. The rationale for ACR TI-RADS is illustrated in this chart. Only a small percentage of thyroid nodules are detected by palpation, less than 10% in some studies. At autopsy series, nodules are found in clinically normal thyroid glands in 50%, whereas high resolution of ultrasound, defined as being 13 megahertz or higher, detects nodules in as many as 68% of thyroid glands. And in fact, I think this number is actually low. In this study, they used a threshold of 5 millimeters for defining a thyroid nodule, but we frequently see nodules that are even smaller. So thyroid nodules are extremely common. And the problem is that the vast majority of them are benign. Only a small percentage, less than 5%, are malignant. Therefore, we need to be able to figure out, based on what we see, which ones deserve further attention. Several professional groups over the years have been involved in this effort. In 2004, the Society of Radiologists in Ultrasound convened a consensus conference in Washington, D.C. And this page from the radiology article that was published the following year shows the consensus statement that was presented. Here's a table from that paper. On the left, we see ultrasound features starting out with more suspicious ones at the top, such as microcalcifications, down to less suspicious nodules, such as mixed solid and cystic. And on the right, you see the corresponding recommendations. As the nodules become less suspicious, the threshold for recommending an FNA in terms of size goes up. And that's a theme that we see in multiple risk stratification systems that have appeared since. The American Thyroid Association has also published guidelines for management of thyroid nodules. And this is a chart from their most recent set of recommendations from 2015. Unlike the table that I just showed you, this is pattern-based. So there are a number of patterns of appearance of ultrasound for thyroid nodules, and you look at a particular nodule, pick the pattern that it most closely matches, and determine management based on that. Unfortunately, this is sometimes problematic because in a number of cases, a particular thyroid nodule will not fit any one of these patterns and therefore won't be classified. Multiple other groups have been involved over the years as well. Several of them have used the acronym TI-RADS based on BI-RADS, which is famous in breast imaging. This is the most recent one from the European Thyroid Association. It was published last year, and they called it EU TI-RADS, EU for Europe. And this is a chart from their paper, and it shows that if you have a nodule in their scheme with at least one high suspicion feature, which they define as a non-oval or round shape, irregular margins, microcalcifications, or marked decreased echogenicity, they consider that high risk. Although, as you can see, there's a wide range of risks in that category. And for that, they say, if the nodule is less than 10 millimeters, you do either FNA or follow it, and FNA if it's larger than 10 millimeters rather than 10 centimeters. There are two things about this I'd like to point out. First of all, is they identified a round shape as being a suspicious feature. And I found that a lot of small nodules, which are hard to measure accurately when they're that tiny, are round. The other is that if you want to be picky about it, their chart doesn't say what to do with a nodule if a nodule is actually exactly 10 millimeters. This says less and this says greater than. But still, they've adopted a general approach that's similar to what other groups have taken. As all this was going on, several people in different countries were looking at what all this was accomplishing. In South Korea, thyroid nodule screening has been offered for a small add-on cost since the late 1990s and early 2000s. And since this was put in place, as you can see in this chart, the incidence of thyroid cancer, mostly papillary, rose tremendously. But if you look at the line that's hugging the x-axis here that represents thyroid cancer mortality, it remained extremely low throughout this period, suggesting that it wasn't having a meaningful effect on patients. This was highlighted in an article in the New England Journal of Medicine in 2016 that we quoted in our white paper. And in this article, it was stated that overdiagnosis of thyroid cancer accounted for a substantial percentage of cases of thyroid cancer in the US, which again suggested that we were seeing a lot of nodules that weren't clinically significant. The basis for ACR TI-RADS was presented in our lexicon paper, which was published in the JACR in 2015. And this table shows the lexicon. There are 5 categories that I'll return to in the TI-RADS chart, ranging composition, echogenicity, shape, margins, and echogenic foci. And I've highlighted in red the more suspicious features in each of those categories. And Bill Middleton will be showing examples of these shortly. In our deliberations, we decided to do several things that departed from what other groups had done. First of all, we wanted to be points-based and not pattern-based for the reason I mentioned earlier related to the ATA guidelines. Second, we wanted no half points because the math would be easier with integers. Third, we decided not to have A, B, and C subcategories as some other systems have used, again, to make it simpler. And finally, no category for normal thyroid because you hardly ever see a normal thyroid anyway, and that would be a good waste of a category. Remember that these are guidelines and not standards. That is, it's up to the practitioner who's reporting a thyroid nodule to decide what to do in a given case, and extenuating circumstances may apply. This is the basis, the central point of ACR TI-RADS. It's our chart. And this is meant to be put up in reading rooms and elsewhere, as I'll describe. Here are the 5 categories at the top: composition, echogenicity, shape, margin, and echogenic foci. In each of these, going from one to the other, you choose the one category that applies for that, the one feature rather that applies for that category, whether it's composition, echogenicity, shape, and margin. The only exception is echogenic foci, the last category, because these features are not mutually exclusive and more than one of them may be present in a given nodule. Once you have all the points, you add them up and you end up with a TI-RADS or TR level, ranging from TR1 to TR5. And the annotations below TR3, TR4, and TR5 indicate what management to recommend based on the maximum dimension of the nodule, whether it's a fine needle aspiration, FNA, or follow-up. If follow-up is not, if the nodule size is below the threshold for follow-up, no further follow-up is recommended. And the boxes at the bottom have explanatory notes that help apply each of these categories. Some of our decision-making in developing ACR TI-RADS was informed by a multi-institutional study that Bill Middleton and co-workers published later that year. And as you can see, as you go up from 0 to 10 points, the risk of cancer goes up as you'd expect. But still, in the intermediate category of TR4, you'll notice that the risk is still fairly low, and it only goes up really much higher in the higher risk category of TR5. I want to spend a moment or two on partially cystic nodules because I think these give people, including myself, problems. It's important to recognize that the appearance of the solid component predominates, and suspicious features of the solid component, including eccentricity, punctate echogenic foci, and lobulation, are concerning. That's illustrated in this image from the literature that shows a partially cystic nodule that has a mural component that has some punctate echogenic foci and is lobulated, and this was a papillary thyroid cancer. A moment or two, I know Bill Middleton will return to this as well, about spongiform nodules, which are not suspicious. To be spongiform, they have to be comprised of at least 50% of small cystic spaces. It's really easy to overcall these, and if any doubt, as in this nodule, it should be called solid. The American Thyroid Association does somewhat the same thing for mixed cystic and solid nodules, and they call attention to these same features of eccentricity that I just mentioned a moment ago. For definition of growth, we offer two options. The first, with just linear dimensions, is a 20% increase in at least two nodule dimensions and a minimal increase of 2 millimeters, or if you want to calculate the volume, a 50% or greater increase, and Bill will show you how to do that. For follow-up intervals, there was not a lot of good material and literature to go on, but we thought that for more suspicious nodules like TR5, more frequent follow-up was warranted. So annually for 5 years for TR5, a little less for TR4, and even less for TR3. And the 5-year threshold was based on some work that shows that if a nodule remains static in size, not changing for 5 years, it's very likely benign. Previously sampled nodules are not encompassed in ACR TI-RADS and may require molecular or gene expression classifier testing, and their management is usually driven by physician request. In multinodular glands, in which there are multiple nodules with similar characteristics, or they're confluent or there's diffuse heterogeneity, FNA is usually not indicated. On the other hand, in a multinodular gland where one nodule is higher risk than the others based on our classification scheme, FNA may be warranted. Here's an example of a heterogeneous gland for which FNA is not indicated. Lymph nodes are not formally included in ACR TI-RADS either. However, their appearance may influence the decision to biopsy a nodule. The lymph nodes may be scanned at the time of the initial sonogram, at the time of the FNA, or subsequently after malignancy has been confirmed. Finally, I want to close with a few points on implementation of ACR TI-RADS from a practical perspective. First, I think it's valuable to give everybody on the team, including physicians, sonographers, or whoever else may be involved, the ACR lexicon and ACR TI-RADS white papers, and then meet as a group to review, so you're all on the same page in terms of what you're doing and how you're describing things. Second, it's very helpful to make the chart available everywhere. And by everywhere, I mean not just in the reading rooms, in the scanning rooms as well, because as I'll mention shortly, it's important for sonographers to be familiar with ACR TI-RADS to know which nodules to target for more images. Third, it's important to agree on a routine scanning and reporting process and to use it consistently. This applies, of course, not only to thyroid scanning, but it especially applies here. Also, it's important to agree on a reporting template and use it consistently, and Jenny will be returning to that in a little while. Finally, some practical points on how to use ACR TI-RADS in your practice. First, review prior scans to see what nodules were previously evaluated. This helps you home in on the same nodules on a subsequent scan. Second, it's valuable to do an overview scan. And again, it's important for the sonographers to know what to look for. So essentially start by scanning through the entire gland. In this case, we're just looking at the right lobe, but start with the entire gland and get the lay of the land, as it were. Decide what nodules look more suspicious, which less suspicious, and that will help determine which nodules warrant further imaging. It's also important not to obsess over features that have identical or very similar point values. For example, hyperechoic and isoechoic nodules have identical point scores. So you don't really have to spend a lot of time considering whether they're hyperechoic or isoechoic. Similarly, with lobulated or irregular margin, this is a lobulated nodule on the left and an irregular margin on the right. They both have the same point score of 2, so you don't have to spend a lot of time deciding which one applies in a given nodule. As well, even if the features are slightly different in point scores, if they're different by 1 point, for example, and applying one or the other doesn't change the TR level, you don't have to worry about that determination as much as you might otherwise would. Fourth tip, ACR TI-RADS says to formally report no more than 4 nodules with the highest point score that warrant FNA or follow-up ultrasound. You do not have to classify every nodule in the gland. That would be time-consuming and wasteful. Similarly, you can recommend FNA for no more than 2 nodules with the highest point scores that warrant FNA. Now, if you have several nodules that have identical point scores or are in the same in the same level, TR level, you can decide which one to recommend biopsy on using other criteria sometimes, such as size or where they are located in the gland. But generally, it's not productive to do a biopsy of more than 2 nodules in a given gland. On reporting, I give recommendations per ACR TI-RADS, but as I mentioned earlier, it's important to consider extenuating circumstances, including comorbidities and other factors such as family history or exposure to radiation. It's important never to say just that a nodule is amenable to biopsy, because every nodule is technically amenable to biopsy, at least almost all of them are, and it's incumbent on us to give recommendations. And finally, this is a question I receive often, you don't have to report the suspicion level. In fact, I never do, because patients see our reports and they will understandably wonder why a TR5 nodule is not being biopsied or followed. And finally, next steps will be continued evaluation of efficacy of our system, which I'm sure will be revised over time, looking at the role of elastography or contrast, and finally on an effort that I've embarked on recently, which is to organize an international symposium to try to harmonize ACR TI-RADS with other systems, because there's more commonality than there are differences between the systems. With that, thank you very much for your attention.
Thank you very much, Franklin. That was an excellent presentation. It really helped to clarify some of the practical points of view of how to get ACR TI-RADS into your practice. We're now going to hand the controls over to Dr. Bill Middleton, who is going to do the next section on imaging examples using ACR TI-RADS. Some people have sent in some questions already, which is great. Keep them coming in. We're going to collate them all at the end and answer them for you. I'll now give the control over to Dr. Bill Middleton. Thank you, Bill. Bill.
I'm sorry, I was still on mute. So,
you sound better.
And people may prefer that I be on mute. My kids often want me on mute. So I'm going to go over image analysis. The first thing that you have to do when you encounter a nodule is to measure it. And it's very important to use a consistent technique so that you can compare nodules over time. The technique that TI-RADS recommends is to measure the longitudinal axis on a sagittal view. When you look at your sagittal view, which is shown in the bottom left, you should mentally outline the nodule. So in this case, we have an ovoid nodule that is slightly off axis with respect to the long axis of the thyroid. You want to measure in the long axis of the nodule itself. So in this case, this measurement would be like this. On the transverse view, we measure both the long axis on the transverse view and the short axis on the transverse view. So 2 measurements are obtained on the transverse view. If we outline the nodule here on this transverse view, we can see that the long axis of the nodule is in this orientation. So that would be one measurement. And then you develop a line perpendicular to the long axis, and you move that line to the point where the nodule is maximum diameter. So this would be the second measurement in the transverse view. So one measurement on a longitudinal view and two measurements on the transverse view. Here's an example of a transverse view where the technique wasn't quite right. The long axis measurement here, the number one measurement, is probably done correctly, but the short axis measurement, number two, is not perpendicular to the long axis. So this would be better if the short axis were measured like this, and that would shave a couple of millimeters off of that result. Now let's move on to analyzing the different characters of the nodule. And the first, which Franklin mentioned, was composition. Composition is very important, and it should be the first thing that you think about. And it's divided into solid, mixed solid and cystic, and spongiform. So a solid nodule is defined as a nodule that is either completely solid or almost completely solid. And by almost completely, we mean greater than or equal to 95% solid. Those nodules get 2 points. Anything other than that is considered a mixed cystic and solid nodule, cystic or spongiform. So mixed cystic and solid gets 1 point. Purely cystic nodules get 0 points, and spongiform nodules also get 0 points. Spongiform nodules are nodules that have an appearance similar to the cut surface of a sponge, as you see in the lower right-hand corner. They consist of cystic spaces of variable sizes that occupy at least 50% of the volume of the nodule. And then in each category, there's a can't tell feature. And this occurs when you just can't figure out what the composition of the nodule is. Usually that's because there's so much shadowing from calcification. So this is a figure similar to the one that Franklin showed you earlier, and it comes from the SRU study that he mentioned. On all of these figures, the risk of cancer in percent is shown on the vertical axis, and then the point distribution is shown on the horizontal axis with the lower points to the left and the higher points to the right. And here you can see the solid nodules with the higher point value have a higher risk of malignancy than the mixed or the spongy nodules. Determining what is 95% can be somewhat difficult. This is a little exercise that I did for myself. Assuming that we had a nodule that was mostly solid and spherical, and within that nodule was a spherical cystic component. So if you image this nodule from slice to slice, you would see images that looked like this sequentially. As you pan through the solid component, you see just solid elements, and then as you pan through the cystic component, you see a cystic element. This is a nodule that's 95% solid. And this is an actual correlate. This is an ovoid nodule, where if you calculate the volume of the nodule itself, it's 5.2. Calculate the volume of this cyst, it's 0.27 cc's, and that results in a 5.2% cystic component. So in other words, a 95% solid component. So this type of nodule would be classified as solid or predominantly solid. Here's another nodule. This is almost entirely solid, although it does have a few little cystic spaces. And in cases like this, the cine clip is very helpful in having you kind of integrate the overall volume of cystic components. This, on the other hand, is a mixed solid and cystic component or nodule. It clearly has a predominance of solid elements within it, but there's enough cystic components that it clearly is not 95% solid. So this would be assigned 1 point and called mixed solid and cystic. This is a spongiform nodule. This is a nodule that is mixed solid and cystic, but the cystic components predominate throughout the nodule, and they vary in size, and they occupy more than 50% of the nodule volume. This is a spongiform nodule that has a lot of relatively large cystic areas. This next nodule is a spongiform nodule where the cystic components are variable in shape. If you look at the two static images above, you can see that there is a solid appearing component here that's less than 50%. And when you actually look at the cine clip, you can see that even that solid component has a lot of little cystic spaces in it. So this also is a spongiform nodule. Now in the can't tell category, these are nodules where you just can't tell the composition. And in this case, there's extensive calcification, mostly peripheral, and the shadow precludes determination of the composition. In this case, you give the nodule 2 points for composition. Now let's move on to another very important category, which is echogenicity. The echogenicity of the nodule should be compared with the ipsilateral thyroid or the strap muscles. If there's not enough normal thyroid on the ipsilateral side to compare, then you can compare to the contralateral side, but try not to do that unless absolutely necessary. Hyperechoic and isoechoic nodules are sort of self-explanatory, and they get 1 point. Realize that if the thyroid gland itself is hypoechoic due to autoimmune disease, you still compare the nodule to the hypoechoic thyroid tissue. Hypoechoic nodules are nodules that are less echogenic than the thyroid parenchyma, but are equal to or more echogenic than the strap muscles or the sternocleidomastoid muscle, and they get 2 points. Very hypoechoic nodules are less echogenic than the thyroid and less echogenic than the overlying musculature. They get 3 points, and if you can't tell the echogenicity, then you assign 1 point. So here's that same graph. You can see that as the point totals go up, the risk of malignancy goes up, and these are divided into solid nodules and into mixed solid and cystic nodules. So this is a nodule that is relatively close in echogenicity to the adjacent thyroid parenchyma. I think in this case, you could tell that this is slightly hyperechoic. Sometimes a good way to accomplish that when you're in doubt is to squint. When you squint, you kind of blur everything, and for whatever reason, it makes it a little bit easier to determine echogenicity. When you're squinting, just be sure don't close your eyes completely. That doesn't tend to work very well. So this is a hyperechoic nodule that gets assigned 1 point. This is another hyperechoic nodule. Now in this case, you don't see much thyroid parenchyma here, but on the transverse view, you can see some thyroid parenchyma that is abnormally hypoechoic because this patient has Hashimoto's disease. And you see the same thing here on the cine clip. So you compare to the thyroid parenchyma that you have, regardless of the echogenicity of the thyroid parenchyma. Here's a large nodule. There's really no adjacent thyroid parenchyma to visualize, so this would be hard to determine the echogenicity. In cases like this, it's very important that the sonographers find some place where they can display the nodule with adjacent normal parenchyma. And in this case, you can see there's a little bit of normal parenchyma in the upper pole that they have on the panoramic view, and the nodule is the same echogenicity as that normal parenchyma. Also remember, as Franklin mentioned earlier, when you have a mixed cystic and solid nodule, you determine echogenicity based on the solid, non-calcified part of the nodule. So if you looked at this overall nodule, you might be tempted to say it's hypoechoic, but when you really analyze the solid component here, it's the same echogenicity as the thyroid parenchyma. So this is an isoechoic nodule. Here's a hypoechoic nodule. Hypoechoic nodules get 2 points. And this is clearly less echogenic than the adjacent thyroid parenchyma, but it's more echogenic than the muscle. So this goes in the hypoechoic category. Also notice there's a lot of through transmission here behind this nodule. That is fairly common with thyroid nodules in general, and it does not mean that the nodule is cystic. If you're in doubt whether a nodule is cystic or not, always try color Doppler. And if you see blood flow in it, like this, you know that it's not a cystic nodule. Now here's another nodule that would fall into the hypoechoic category. It is hypoechoic to the thyroid tissue, but it's isoechoic to the overlying strap muscle. You don't call a nodule very hypoechoic until it reaches this degree of hypoechogenicity, until it's actually less echogenic than the overlying musculature. And sometimes that's a little bit easier to determine if you turn your gain up just a little bit. It somehow makes the difference in echogenicity more prominent. So this is a nodule that's a little less echogenic than the overlying strap muscles. And here's another very hypoechoic nodule. You see here on the static image, this actually looks like it's cystic. It's that hypoechoic. It's about the same echogenicity as the adjacent common carotid artery. And you can see the marked hypoechogenicity here on the strap or on the cine clip. Again, notice that the vascularity here is extremely high, so that clearly is not a complex cystic nodule. Now, what about nodules where you can't tell? Here's another patient where there is so much calcification that you can't see what the composition, or in this case, what the echogenicity is. So this gets 1 point. And in this case, we ended up biopsy. You can see how calcified it is because the nodule moves with the needle rather than the needle moving through the nodule. The only reason that this was biopsied was because a node had been sampled while they were doing a lymphadenectomy for melanoma, and a node came back as positive for thyroid cancer. Next, we move on to margins. Margins are divided into ill-defined, smooth, irregular lobulated, and extrathyroidal extension. Ill-defined is determined when the nodule is just really difficult to distinguish from the adjacent thyroid parenchyma. That makes it difficult to make an outline of the nodule or to measure the nodule. That gets 0 points. Smooth is self-explanatory. That also gets 0 points. Irregular or lobulated refers to either large or small lobulations. Franklin showed you a couple of cases with relatively large lobulations. And irregular sometimes is referred to as spiculated or jagged. Those nodules get 2 points. If you see extrathyroidal extension, and that means you clearly see some of the, some of the nodule extending into the parathyroidal tissues, that gets 3 points. Now, you can't call extrathyroidal extension if there's just a bulge in the capsule. You have to actually see extension. A bulge in the capsule might indicate some extracapsular or extrathyroidal extension, but that's not necessarily the case. Again, you can see smooth nodules have a lower risk than lobulated or irregular nodules. Here's a nodule that's relatively isoechoic. That makes it hard to define the margins. So this would fall into the ill-defined category. Here's a nodule where the margins are very well demarcated. It's a nice round nodule. This would also get 0 points. This is a nodule that's irregular. If you look at the static image, you see all these little jagged spiculations extending into the adjacent thyroid parenchyma, also seen on that cine clip. And this is a nodule that's lobulated. You can see the lobulations on this border and over on this border on the transverse, and see them throughout on the on the other view. This is a nodule where you have clear cut extrathyroidal extension. There's a little piece of that nodule that's extending outside the margins of the thyroid, better seen on the cine clip here. And then finally, or next to last, is shape. Shape is determined on the transverse view, and this is where we refer to nodules being wider than tall or taller than wide. So wider than tall gets 0 points. And you occasionally will have nodules where the width is equivalent to the height. You can call those not taller than wide. they also get 0 points. If a nodule has AP dimension greater than the transverse dimension, that's called taller than wide, and those get 3 points. Those are basically nodules that are growing against the normal tissue planes. So here's a transverse view of a spongiform nodule. You can see that this dimension is bigger than this dimension. This is a wider than tall nodule, 0 points. Here's a nodule where the two dimensions are identical. So this is not wider than tall, but it's not taller than wide. So if it's not taller than wide, you assign 0 points. And then finally, these are two different patients with nodules that are both taller than wide. So this dimension in the AP direction is greater than in the transverse direction. Finally, we have echogenic foci, or calcifications. And these are divided into comet tails, macro, peripheral, and punctate echogenic foci. So if there are no calcifications, 0 points. Comet tails are also 0 points, and that can only be diagnosed when the comet tail itself is greater than 1 millimeter. Macrocalcifications are defined as calcifications that are shadowing. If they don't shadow, it's not a macrocalcification. That gets 1 point. Peripheral calcifications can either be complete or partial. They get 2 points. And then punctate echogenic foci are small reflectors that have no shadowing and have either no comet tails or maybe occasionally a small comet tail. You can see how the risk of malignancy increases as the points for calcifications increase. Also notice that, as Franklin mentioned earlier, that you sometimes will have cases where there are different types of calcification. So for instance, this one has peripheral and macrocalcification. And notice that that combination there increases the risk of cancer above the risk for peripheral calcifications or macrocalcifications individually. This is a large comet tail, which we get 0 points. We see it right here, and we know that it's large because it's bigger than 1 millimeter. At this depth and this scale, this is 2.5 millimeters. So if you take that 2.5 millimeters and compare it to that comet tail, you can see that it's almost 2.5 millimeters, clearly more than 1 millimeter. On the other hand, this is a patient where there is a little comet tail associated with this nodule, but if you look at the scale, this is 1 millimeter here. This is a very magnified image. And when you compare the nodule to the scale, this is less than 1 millimeter. So this would fall under the punctate echogenic foci category. Macrocalcifications are calcifications that shadow. They're usually big and chunky like this. They get 1 point. Occasionally, you'll have a tiny little calcification, as we see here, that you'd be tempted to call a punctate echogenic focus, but if it shadows like this, then it falls into the macro category. These are peripheral calcifications. Peripheral calcifications can be very limited and partial, or they can be extensive and thick and completely encompass the circumference of the nodule. All of these would fall into the peripheral calcification category and receive 2 points. And then we get to punctate echogenic foci, or PEFs. This is a nodule that's lobulated and has all these tiny little echogenic foci scattered throughout, none of which have comet tails or shadowing. You can see it a little better on the cine clip. This is another nodule with punctate echogenic foci, just to give you a feel for that. And as I mentioned earlier, some nodules have more than one type of calcification. This nodule has some punctate echogenic foci as well as some shadowing macrocalcifications. So this gets 1 point for macrocalcs, 3 points for PEFs, so a total point total of 4. And that does it for image analysis. Thank you all very much for your attention. Jenny, you can take over at this point.
Right. Thank you so much, Bill. Beautiful imaging examples, crystal clear presentation, and we really appreciate the cine clips. But please, everybody, keep your eyes open, don't squint or close your eyes, as Bill suggested. So now with that, you might be wondering, how do I put this in practice? How do I start? And the first step is to use a structured reporting template. As I mentioned, I am running a multi-center study with a registry, and so I wanted to show you what template we're using for our study. This is a template, and all of this is for just one nodule. We'd be describing the nodule number, the maximum size, the other dimensions, and the location. Then this part is the 5 features, and it looks like a large piece of text, but remember these are pick lists, and so for composition you would just pick whether it was solid, almost completely solid. And here, as part of the structured reporting template, I thought this was a great idea to put in the points that it is worth, so you don't actually have to refer back to the chart each time. Then, after you've assessed the nodule for all of these 5 features, it's about adding the points up, and from the top part you can add up the points, and then based on the total points you choose a risk category, and once again the risk category pick list has the definition of the points it's worth. Then if your nodule has been imaged before, there are 3 questions to put into the report. Is there a change? And again, there's the definition of change in the structured reporting template. Whether there's a change in features, simply yes or no, and you may choose to describe it further, change in the risk category. And then finally, you give the TI-RADS recommendation based on the risk category and the nodule size. Now, all of this is essential for a research registry because we need standardized data elements to collect the data. And for those of you who are not participating in research, you may be thinking, well, this is too long for my practice. It's really not practical to use something like this. Can't I just free text what I'm seeing and then refer to the chart? Well, let me show you a study that clearly shows that a structured reporting template like this with a checklist is very valuable. This is a study that is now in press in JACR. It was a study that was performed with private practice radiologists at Radiology Partners. And shout out to Radiology Partners there. This is a study that was performed in 3 phases. In phase 1, we simply used free text of their reports. In phase 2, 7 of these private practice radiologists were asked to use the TI-RADS lexicon, so just describing the 5 features. And then in phase 3, this was when the TI-RADS paper was published, and the radiologists were then given the structured reporting template again with the TI-RADS risk category and the management recommendations. This is a graph that shows the management recommendations for each of those 3 phases, with the dark blue being phase 1 of just free text, the light blue being the structured reporting template without the recommendations, and the gray being a full ACR TI-RADS structured reporting template, as you saw on that previous slide. As you can see, the number of biopsy recommendations for nodules recommended mentioned in the impression of the report did not change at all, and I was surprised with that result. But what did change were nodules that were mentioned in the impression of the report that simply had no recommendation at all. And without a definitive recommendation, which was the case in 1/3 of the nodules without ACR TI-RADS, then patients and the referrers were left with what to do. And many of these nodules may have been biopsied or followed up unnecessarily. What was also interesting in this study was the description of the features in phase 1 compared to phase 2 and 3. In phase 1, which was just free text, where radiologists were left to describe the nodule as they wished to, composition was mentioned the most, but still not all the time, and features that are important such as shape, margin, and echogenic foci were infrequently mentioned. With a structured reporting template and a checklist, in phase 3, all of these signs were mentioned for every nodule described in the impression of the report. Now, the next question is, just because it wasn't mentioned, maybe the feature wasn't there and it wasn't worth mentioning. Well, then we looked at the frequency of the suspicious findings, and we saw that tall and wide shape was not mentioned in free text, but it wasn't zero frequency. Up to 8% of those nodules had a taller than wide shape when there was a checklist to look to. And then same thing for suspicious margins. 1% had a suspicious margin where it was irregular or lobulated, but the frequency of a suspicious margin was much higher when the radiologists were prompted to use a structured reporting template and check off the margin. And so as a result, the average TI-RADS score in phase 1 was 3.1, which would make it a TI-RADS 3, but in phase 2 and 3, it was 4 as an average, which definitely makes it more suspicious. So the result of this is that the same number of biopsies were recommended when there was ACR TI-RADS. That's not because ACR TI-RADS recommended more nodules, but radiologists were seeing more of these suspicious findings when they had a checklist. Now, if you're interested in using that structured reporting template, the template is available on the ACR TI-RADS website. Here is the URL to access that website. And on this website, you'll see other educational resources. We have the JSE publications, an atlas, and a structured reporting template also for nodule biopsies. The future webinars are here, so mark these on your calendar and sign up now so you'll get the reminders. The next one will be on case-based review and frequently answered questions, and I think that session is necessary because we don't have time to answer all the questions we've got today. And then the final webinar will be the evidence behind why to adopt ACR TI-RADS in comparison to other risk stratification systems. So now we reached the point where we're taking your questions. Once again, the URL for the ACR website is down the bottom for you to copy here. And let me take a look at the questions. I think I'll address the first question to Franklin. This comes from Daniel. And Carver also asked a similar question, as well as Tanman. Franklin, are you off mute?
I'm here.
Yes. Okay. So the question is, what do you do with a TI-RADS 4 or a TI-RADS 5 nodule which don't meet the size criteria for biopsy or follow-up?
In those cases, I follow the recommendations as outlined in the white paper and we've discussed today. I say specifically that no FNA or follow-up is recommended. I understand that some people are uncomfortable doing that, but as Bill mentioned and as I mentioned earlier, in the intermediate category, say TR4, which is actually higher than intermediate, it's the almost the highest category, the risk of cancer is still fairly low. Even based on Bill's study, even at 6 points, the risk of cancer was less than 13%. And in the highest category, TR5, we're recommending follow-up of very small nodules. And at that level, what we're doing is very congruent with what other professional groups are recommending. I think it's really important here to get out of the mindset of having to identify and follow every cancer, because thyroid cancer biologically is not the same as breast or lung cancer or other aggressive malignancies. Okay. Bill, do you have anything to add to that?
No, I completely agree. The problem with thyroid cancer is not underdiagnosis. The problem is overdiagnosis. Almost everybody agrees with that now. And there's a lot of thyroid cancers that that we're detecting that in the past would never have been detected and would never have been, symptomatic. So I don't think that people need to worry that much about missing these, small cancers. And by the way, many of these nodules in the categories that, that we're talking about will not be cancers. In fact, in the TR4 category, only at the most 1 out of 5 will be cancer, and it will, in most cases, it will be less than that.
Great. Bill, I have a question for you. It's about punctate echogenic foci. The question is from Claudia. What do you do with small echogenic foci that don't look like microcalcifications? And specifically on how do you distinguish them from tiny colloid calcifications? Do you ever struggle with that?
I struggle with that daily, and that's a great question. And I wish that there were a way to, reliably tell the difference between PEFs and little areas of crystalline colloid reliably. The pattern that I take is if I see them in cystic components of a mixed cystic and solid nodule, I don't worry about them. If I see them in solid components of a solid nodule or a mixed solid and cystic nodule, and there's not a long COMET tail, then I assume that they're PEFs.
Okay, that's very helpful. Okay, Franklin, back to you. Do you ever use TI-RADS for pediatric patients? This is from Claudia. In our hospital, the endocrinologists mainly follow ATA recommendations for pediatric patients.
That's an excellent question. I've received it from some practitioners here at UAB as well. Formally, ACR TI-RADS only applies to the adult population. I think that for pediatric patients that are in the close to adult range, it's probably reasonable to apply ACR TI-RADS. But once you get to much younger patients who have a higher risk of cancer, I think that I wouldn't say that all bets are off, but you have to be much more careful about calling nodules, saying that they're benign or don't need follow-up based on ACR TI-RADS. And there are several publications in the literature that address how to manage pediatric patients with thyroid nodules.
Okay, great. Bill, this question is from you. It's from Jimmy. How do you classify margin for partially or mixed solid cystic nodules? Is the margin defined by the solid component, or do you take the solid cystic component?
Well, another good question. That sort of depends on the type of mixed cystic and solid nodule. So if it's that type of nodule that Franklin showed from the Korean paper, where there's a cyst with a mural nodule, then you analyze the margins of the mural nodule itself. So the mural nodule may have, lobulated borders that would, at least in the way that I do it, that would give them the 2 points for lobulations. For other cystic and solid nodules, you basically do it the same way as you do, for the solid nodules. You look at the periphery of the nodule and look for lobulations, which you occasionally will see with mixed cystic and solid nodules, or you look for irregularity, which is much less common with cystic and solid nodules.
Great, thank you. Well, I think that our time is up. We have so many more questions to answer, and as I mentioned before, we are going to address it in the next webinar. I thank you very much for your time, everybody that signed in and listened, and the people that are also listening after it's been recorded. It's great that you've taken the time to learn more about ACR TI-RADS, and we are definitely wanting to hear your thoughts. So email us at ACR, give us comments about how we can improve this, and sign up for the next webinars. Thank you very much, everybody. Thank you, Franklin. Thank you, Bill. And thank you, Lauren, for helping us organize this.
Thanks, everybody.
And thanks, Jenny.
Yes, absolutely.
Bye-bye, everybody. See you next time in April. Bye.